Very good morning to all. Today I'm going to take a class on trigeminal neuralgia. So today I'm going to talk about the contents, definition, pathophysiology, etiology, clinical features, and differential diagnosis, and little about the glossopharyngeal neuralgia and the treatment aspect. So by the definition, trigeminal neuralgia is a disorder characterized by severe paroxysmal episode of pain that occurs along the distribution of any three branches of trigeminal nerve. It was discovered by John Fortil in 1973. It is also called as the synonym of stick dolorous, trifacial neuralgia, Fortagillis disease, and suicidal disease. And trigeminal nerve, as you all know, the trigeminal nerve has three divisions, such as ophthalmic division, maxillary division, and mandibular division. Out of these, the maxillary and mandibular branches are almost affected. So the ophthalmic branch is least affected in this scenario. So moving on to the classification. The classification, international classification for headache disorder subdivided trigeminal neuralgia into mainly two categories. First one is classical trigeminal neuralgia and symptomatic. Second one is a symptomatic trigeminal neuralgia. The classical trigeminal neuralgia is the most common form, which is idiopathic in nature and associated with vascular compression. And symptomatic trigeminal neuralgia, it's caused by demonstrable structural lesions other than the vascular compression. The other than the vascular compression, anything, it can be subdivided into symptomatic trigeminal neuralgia. Moving on to etiology, the first one is infection, is due to various granulomatous and non-granulomatous infection involving in the fifth cranial nerve is one of the main reasons. Then other reasons like dental etiology, multiple sclerosis, dental pathosis, petrous rigidae compression, and traumatic neuralgia and intracranial tumors and viral etiology are the other etiologies characterized. And the general characteristics involve incidence. It's seen about 4 in a 1 lakh persons. So the incidence was very low, but the incidence was increasing drastically with the newer decades. Okay. The age is mainly is a middle-aged. It's mostly in the 5th and 6th decade of life. And the sex predilections, the female are more commonly affected than the males. The nerve branch involved mostly is commonly is a mandibular nerve, and right side is the most affected in the affected areas. And moving on to clinical features. The clinical features typically manifest as sudden unilateral intermittent paroxysmal pain, sharp shooting, lancerating shock-like pain. This is elicited by the slight touch or superficial trigger points which radiates. Pain is usually confined to the part of the division of the trigeminal nerve. Pain rarely crosses the midline. Is trigeminal neuralgia basically sudden stabbing and shocking facial pain? It seems to be come from the nerve. So during an attack, the patient dreams his pain and clutches his hands over the affected side of the face and stopping all the activities holding his face, which may be reddened eyes. The extreme cases, the patient will be motionless face and frozen mask-like face. It is a characteristic of the disorder that attack to not occur during the sleep. Many patients will lead the poor quality of life because due to the excruciating pain from the side of the face. So moving on to Sweet's criteria. So there is a criteria which is introduced, White and Sweet, in 1955. Described a set of criteria which is diagnosing the trigeminal neuralgia. There are the pain is paroxysmal and sudden in nature. The light touch onto the face on the trigger zones provoke the pain, and the pain is confined to trigeminal nerve distribution. The pain is limited manifestation and clinical and neurological examination was normal. So the main areas involved, we can see in this picture, the main areas involved the maxillary division and the mandibular division. That is V2 and V3 divisions are more involved in the case. The most of the time, the mandibular lobe, that is the 15% is seen in the mandibular area alone. So more than 50% of the patient experience early remission greater than 6 months before the return of active pain. The several patients have reported to have many last for a long time as a burning ache, which is suicidal tendency to rid of themselves from the pain. The severe pain, as it fades away, may give rise to the burning ache that may last for a long time after an attack. Moving on to differential diagnosis, TMJ-related disorders, odontogenic causes, glossopharyngeal neuralgia, migraine, atypical facial pain, multiple sclerosis, and post-herpetic neuralgia. So moving on to glossopharyngeal neuralgia, the first differential diagnosis. The glossopharyngeal neuralgia is a neuropathy similar to trigeminal neuralgia. Harris conducted a term glossopharyngeal neuralgia. This condition less seen in comparison with trigeminal neuralgia. So what are the triggering factors? Smiling, chewing, swallowing, whistling movement, speech, yawning, and coughing are the triggering factors. So moving on to treatment plan, most primarily and secondary trigeminal neuralgia can be treated by medication, alcohol, injection, and surgery. Moving on to the medication part, the carbamazepine, initial dose of 200 mg per day, it can be further increased to 800 to 1000 milligram per day. Then baclofen, 5 mg TID, the maximum dosage is 8 mg per day. And the phenytoin sodium also can be used for this. So second one is the alcohol injection, 2 ml absolute alcohol mixed with 0.5 ml or 2% local anesthetic solution, which is injected into the mandibular foramen as a mandibular injection. Surgery, when the pain is, the third one is a surgery. When the pain is not responding to the medication and the alcohol injection, the surgery can be carried out for treatment for the neuralgia. So the trigeminal neuralgia, what are the medications? Carbamazepine we can use, phenytoin sodium we can use, chlorazepam we can use, valproate you can use, febamate you can use, gabapentin, and oxycarbamazepine. So various surgical procedures such as microvascular decompression, radiofrequency thermocoagulation of trigeminal ganglion, and surgical and razor removal of pathology. So moving on to the conclusion part, the pain is confined to the trigeminal neuralgia nearly always unilateral, if bilateral, if is successive rather than the commitment. The trigeminal neuralgia is an extremely painful condition as it's unique of all moments. It is a common most fourth orofacial pain. So the proper treatment plan and knowledge of clinical features and diagnosis is very important. Thank you.